Good afternoon. Thank you all for coming. This is the third lecture in the series on pain. Unfortunately, last week's lecture was canceled, and I apologize. It was a medical issue with the speaker, and I'm hoping to reschedule it after this 6 lecture series is over. So it would be, I think, February something. If possible, if the speaker is available, we will have the lecture then. But today's speaker is Dr. Mark Bishop. He's a professor at the University of Florida, and he's a physical therapist by training. He received his physical therapy or physiotherapy training in Australia, and then he moved to Canada. He worked there for some time and came to Gainesville from there. Here at the University of Florida, obtained his master's in health science, and then went on to get a PhD in rehabilitation science. He's currently professor in the program in the Department of Physical Therapy, and I'm not even going to try and say what college it is. Very confusing. College of Public Health and Human Performance and Health Professions. Okay. CA, Public Health and Health Professions. Okay, college. He teaches both at the undergraduate and professional levels, post-professional residency programs, and PhD students. He's part of the pain research community at UF and studies factors that led to the development and maintenance of musculoskeletal pain, as well as the management of pain by manual therapy. His work is funded by the National Institute of Health, the Florida Department of Health, as well as by foundations such as the Brooks Endowment, the Ida May Foundation, and the Academy of Orthopedic Physical Therapy. He's currently the director of the Center for Pain Research and Behavioral Health at UF. Please welcome Dr. Mark Bishop.
All right. Is that sounds awfully loud. All right. Just keep talking. Magic will happen in the background, and then we'll be great. All right. Thank you, everybody. So yes, Mark Bishop. I'm a physical therapist in the United States here, and so when I received the invitation to talk, very excited. Have spent maybe 35 years thinking about other people's pain, why some people recover and why some people don't, and what sort of things can we do to facilitate that. Currently, I direct the Center for Pain Research and Behavioral Health, and our focus really, you met Roger Fillingim, and so he directs the Pain Research and Intervention Center of Excellence. You might say, why are there two pain centers on campus? Our pain center is really focused on the patient's treatment part. I'm probably not smart enough to study mechanisms and things like that. And so Rogers Institute is really focused on understanding the mechanisms underpinning things, cellular, logical. And our center is, let's say, what do we do with that? I'm a physical therapist. How do I take what you just developed and can we use that for patients? And so part of the way I've put the talk together today is related to thinking about the scope of back pain, anatomy, some reasons why perhaps we can't tell exactly what's going on. However, I've been asked a lot of questions as I've been walking around that people also want to know about treatment. So I will talk about treatment once we get there. Okay. So first question, how many people here have ever experienced an episode of back pain? Right? So statistically, lifetime prevalence is remarkably high. I think we just just proved that we match what the studies show, that most people will experience an episode of back pain during their life. When we look at the epidemiology of it, when you ask people, have you experienced back pain in the past 3 months? That's still pretty high to think that 40% of people are experiencing pain at any 3-month period. And about 28-30%, depending on your reference, the pain is considered chronic. So if Roger went through those definitions, chronic pain is any pain that is still there when it's no longer useful. Right? So what is pain for? Why do we feel pain? It's an alarm to tell me something's wrong. And so you have to feel pain. The people who congenitally can't feel pain often don't live very long because they can't protect themselves. So you have to feel pain. But if it's no longer serving that purpose, then it becomes problematic. And this is definitions of chronicity. People will say it's been there every day for 3 months, or it's been there for more than half the days over 6 months, based on what we know about how we heal. So you're probably still not in an acute inflammatory state at 6 months. So that is not. That's about 30% of people with chronic pain. That pain is no longer serving its use. As we think about the treatment for this, it's 30 million people getting treatment for back pain. It is the primary reason that people will go, take that back, that was pretty egocentric. Pain is the primary reason people will seek care. Back pain makes up about 60% of all the musculoskeletal pain cases. So it is the most common pain condition that people go and see a provider for. Millions of emergency room visits. People get hospitalized for it. I'm just going to go to some of the costs, because in this particular figure, some people at the top that's under the closed captions, some people will notice, 2013, that's old. So I have another figure that's 2021 that shows that it's matching, but it says that musculoskeletal pain is about the third largest consumer of our healthcare dollars. More than cancer. I'm not, please do not hear me say that pain is worse than cancer. What I'm saying is we spend a lot of money on managing pain. Here in this particular figure, you'll see that musculoskeletal complaints are about 10% of the total. And it turns out, I'm just going to change this to a different sort of format. This is 2021's health expenditure data. And I think musculoskeletal pain is about 9% of the total. So still pretty consistent over the past 15 years, decade, to say that pain is a big consumer of our healthcare dollars. Back pain specifically in direct costs. That is a lot of money to spend on any sort of pain. But so that's how much our direct costs and direct healthcare costs are things like how much it costs me to go and see my primary care physician, did I get imaging, did I have any other sort of procedures done? So that's direct costs. Part of those direct costs are surgical costs. So it costs you almost $90,000 if you need a spinal fusion, for example. That's the cost of the surgery, not of everything that has to happen to support the surgery, by the way, just the surgery. The other part of back pain in particular that seems to have a pretty big societal cost is the extra part of it. I don't know if you've had to take some time off work because of your back pain. I have in various times needed time off, which when you build in, they call these the productivity costs. Back pain is up around the $200, $300 billion cost to our healthcare system. So on the scale of big problems, it's right up there. So let me whirl you through some anatomy here. How many physiologists in the room? Physiologists. Couple. How many? What about anatomy people? How many people are physicians, nursing? All right. So we'll just carry on. Right. So here we are, pretty familiar with this particular anatomy, I presume. So we're looking at the lumbar vertebrae here are highlighted. Directly below that is a set of fused vertebrae. Right. Your sacrum has 5 vertebral bodies, 5 sets of transverse processes. They're just fused together. And then your coccyx. I'm not going to talk specifically about the coccyx, but anyone who's landed on their backside and injured that joint, I'm sure will share with you that that can be a source of pretty intense pain. Okay. So we've got, these are the vertebral bodies that kind of make up the complex we're going to talk about. Then your pelvis, 2 halves to the pelvis. The pelvis is going to attach to this big foramen right here, and that's your sacrum, sacroiliac joint. So if you've heard of your sacroiliac joint, this would right here where the pelvis articulates with the sacrum. So those joints in between the vertebral bodies here, we have the joints between the vertebral bodies, actual diarthrodial joints. For the Greek scholars in the room, zygapophyseal joints. Zygos is an arch. So you've got these arch bridges between the vertebral bodies. You also have the inner vertebral disc. I will tell some terribly boring stories about shortly because it's fascinating, as well as some of the other articular processes. So vertebrae, joints, discs in between. As we look over here on the right-hand side, this is a shot transverse plane, so we're looking straight down on top of the vertebral body. And just to orient folks, probably very familiar, here's your spinal cord sitting in this space at the back of the vertebral body. Spinal nerves, right, where they exit in these lateral foramina here. These little fellas, this is part of your sympathetic nervous system. And that's my aorta right there. So this is the front, this is the back. And I put these things up here because then we'll talk about in a second that anything that has a nerve supply can be a source of pain. So I'm just showing you all the different structures in here. And you say, why does my back hurt? Well, we've got a couple of things we might want to check, including all this. All right, so this is a picture from behind of all the ligaments in this area. All the ligaments between each of the vertebral bodies, spinous process, transverse process, sacroiliac ligament here, long dorsal ligament, big ligaments down this one, sacrotuberous ligament, your hamstring's attached to this one. Every one of these ligaments has helped reinforcing this posterior aspect of the spine and sacroiliac joint. Next layer up on top of that, these are the deep muscles, the multifidi. So you're getting a kind of picture of all the stuff that's stuffed into this 12-centimeter block that makes up your lumbar spine. The challenge with having all that stuff is that a specific diagnosis is actually remarkably difficult to make. Maybe 5, 10, 15% of cases can you actually say this pathology caused this problem. That means the rest of the time, we're not really sure exactly, precisely, which singular structure was the cause. This has been well known for a very long time. I put up this reference here from White, wrote a great book called The Low Back in 1982. And they're still talking about it in BMJ right now, about how difficult it is to actually identify any particular structure. So hold in your mind that picture that we just showed of all the different vertebrae, all the different ligaments, all the different muscles, all stuffed into that one 12 to 18 centimeter region. Someone much smarter than me once said there's 108 different pain generators in that block of space. And every single one of them by themselves or in combination can give you local pain in the back or pain down into the leg. So I'll show you some of that data in a second, but that's why it's so difficult for someone to be able to tell you this is exactly what you have. I would say that we can get pretty good at saying, look, this is probably a joint problem. This is probably a muscle problem. But to tell you precisely which one is what's challenging. Okay, the 5%, 10%. So I have some pictures coming up so that I'm going to move the captions in a sec. But pathologies that can be pretty well picked up and do have a good relationship. The first one is stenosis. Stenosis is narrowing. And so in our cartoon up here, I hope you can kind of see in the cartoon version is that this space gets narrower. So this is central stenosis. Right, that's something you can match the pathology to the symptoms. You can also have the not advancing. Yes, ma'am. You can also have the same sort of narrowing happen. This is a fracture, spondylolisthesis. So this is a fracture that's letting the vertebral body slide forward. Hopefully you can imagine that makes that pretty narrow. So that would be an instability source of stenosis. You have things that happen with the disc. So to tell you this story, I have to tell you about the disc. The disc is made up, it's got a cartilage ring on the outside, that's an annulus, and then it's got something in the middle, nucleus pulposus. All right, can I see everyone who is between 20 and 30? Raise your hand. Yeah, so when between 20 and 30, the disc actually is hydrophilic, so it sucks water in based on the glycosaminoglycans inside the disc. When I'm 20, I have a lot of those, and my disc looks like toothpaste. Once you get to the 6th decade, 7th decade, the consistency is not so much toothpaste, more like that old wood putty that you found out in the shed. You're trying to squirt out the tube. So metaphorically, I hope it makes sense that as we talk about these disc conditions, they will vary by age quite a bit. And so a herniated nucleus means that the nuclear material squirted out into space. Only toothpaste can squirt. My wood putty doesn't so much squirt as crumble. Thank you very much. I appreciate the laugh. Right, and so the herniations, the herniations that squirt out are probably someone who's 20, 30, maybe mid to late 30s. And the reason that's important is because in a design flaw, the nucleus has an enzyme in it. Someone probably knows it, PLA2 something or other. And your body is intensely allergic to it. It doesn't make any sense, but I squirt this nuclear material out of my disc onto a spinal nerve. My body goes, ah, big inflammatory response. I get a massive dose of sharp pain, probably not weakness, probably not changes in reflexes, but I get this intense pain all the way down my leg, my arm. But in 72 to 96 hours, that's beginning to resolve and change as my body absorbs all this stuff. So that if nuclear material has herniated, it quite often is in that type of framework. Once you get to at least 60s, we're a bit more crumbly with our discs. And so you're more likely to have a protrusion or a bulge or something that occupies space, causes compression. So what do your nerves do? What are nerves for? Transmitting signals. And so in my very primitive brain, if I kink the hose, if I compress the hose, the amount of transmission of fluid decreases. And so compression is going to cause numbness, maybe tingling. Gets enough compression, you'll get weakness, lose reflexes. So you're more likely to have a compression injury at this particular point. Don't get me wrong, it still hurts like the dickens because irritated nerve is still going to be painful when I push on it, pinch it, but it'll be associated with all these other signs of compression. Other things that are identifiable and important to think about: fractures, usually can find those pretty easily, spinal infection, rheumatological arthritis and conditions, and cancer. And so this is the group or the cluster that people feel pretty confident, say, yes, I identified this. It is probably related to what you're feeling. Just FYI, signs of these serious pathologies to think about. Generally, changes in bowel or bladder function. Either you can't go when you want to, or you can't stop yourself from going, so a change in that function. Numbness and tingling through the peritoneum, also a sign that there's some pretty serious compression happening in the spinal cord. Distal weakness. Anyone ever seen someone with a foot drop from weakness in the periphery? So that type of weakness, particularly if it's getting worse, just go. So my weakness is getting worse with my back pain. That would actually be a pretty emergent sign to say we should do something because the compression is really progressing quite a lot. Pain that never changes. This is different from I always have pain. This is pain that never changes. I can't do anything to make it worse. I can't do anything to make it better. Now that's not typical. If it's a mechanical problem, I should do something mechanically to make it worse. But if there's nothing that changes it, that's a pretty serious thing to think about. And then night sweats and any sudden weight loss that you weren't planning. Might be some metabolic or physiological things. All right, so that's our 10%. So what about the rest? Well, I've been a physio for a long time. We've made up a lot of things. All right, we've made up myofascial pain, thigh dysfunction, internal disc disruption, facet syndrome. And I put herniated nucleus up here again because people will often say, oh, I think think your disc is your problem. We'll talk about why that can't be all the time. And that's mainly because all these conditions have been proven for decades now that they can't be identified just with eye questions, imaging, and tests and measures. They're resistant to all those things. Turns out this is also the case for the shoulder. So the problem with the back is, as we talked about, the location of the pain doesn't really give me a definitive problem. 108 different things. Right? Any structure that's innervated can be a source of local and referred pain. So what I'm going to show you is Oh, that again. Yeah, there's all the things that can refer the pain. But this is a classic study, 1930s, where they injected saline into the interspinous ligament. So this tiny little ligament right at the top of the back, in between the vertebral bodies. And they had people volunteer for that. This is what always makes me kind of chuckle a little bit. You volunteered for this, big fella. So lie down and they inject these ligaments with hypertonic saline, which really is unpleasant, and then had them map where did you feel pain from that? Right? And so if you look at this graph, this is just a little ligament, tiny little ligament. And it referred, the most common referral pattern was posterior leg pain. Buttock pain. And you say, okay, well, that was 1930. Well, apparently they got people to volunteer for it again recently, and they've kind of redone some of it in the back muscles. I'm just going to show you those data. They will take, say, back muscles at L4. And this is what it looked like when they injected the back muscles in L4. Actually pretty similar to injecting the ligaments at L4. I think L4 is the link, not the structure. And one more thing I'm going to say, just put them next to each other. They're almost exactly the same, but one is a set of muscles, more than one, and the other is a tiny little ligament. So if you come to see me and say, oh, I have pain in my hip running down the outside of my back of my leg, there's no way if I can tell you if that's ligament or muscle. Is it neural? It's probably a way I can tell you. Generally, I think there's a muscular component. But if anyone's really definitive, call them on it and say, well, what about the Kalra study of 1937? So this kind of complicates things when people are trying to come up with a definitive diagnosis, and probably better that the movement, chiropractic, PT, osteopathic medicine is more like classifying, saying this is a joint-based problem. We're going to treat it with joint-based techniques. This is a muscle-oriented problem. We'll treat it with muscle-oriented techniques. So at least in rehabilitation disciplines, that's where they're moving with this sort of process. All right. The other thing that really makes this tricky is the high rate of asymptomatic pathology. I say pathology because pathology implies that it's not right, but it's actually just normal, typical. I threw this up actually just for once in my life, recognizing who my audience was, to say, as you look at that, the rates of these pathologies keep increasing as we get older. This is asymptomatic. This means you go in, I go in, and they do a CT scan of my back, MRI of my back. That's a lot of people who don't have any pain to have a pathology. So I think intuitively, if you think about that, at least I think it makes sense to say that's why perhaps imaging hasn't been as effective a tool as we thought it would be. Right, so I'm almost just under 60, 88% prevalence of at least one disc herniation. I don't have back pain right now. I periodically have back pain. But if I have back pain and I go to anyone, a PT, a physician, anyone who orders some imaging, and they say, oh, look at that herniation. That's it. Maybe not. Right? Other things up there which I think are useful for us to think about is his spondylolisthesis. That was the fracture. 50% of us have a spondylolisthesis that we don't know about. So is spondylolisthesis something we have to treat? Not unless it's the cause of the numbness in your foot and the pain in your leg. But just because you have a spondylolisthesis doesn't mean it's the cause of your pain. So I threw up a couple of images here for you to have a look at. Step back a little bit. Can you see all right if I'm here? And so on these ones, hopefully you can see that looks like a lot of disc material hanging out in the spinal canal. These are asymptomatic images. Take it back, terrible thing to say. These are images from asymptomatic people. It looks pretty bad. That looks problematic. This person didn't have any pain. They're a pain-free volunteer. Big herniation here causing some sort of compression. These are all asymptomatic volunteers. A Schmall's node, incidental finding. You know what a Schmall's node is? That's like where your disc herniation is up into the vertebral body. Sounds terrible. This is an incidental finding, meaning the person didn't have any back pain. They just got imaged and said, holy cow, man, you have a Schmall's node. Are you okay? I got a what? Right, so it obviously can happen asymptomatically. It doesn't have to be treated immediately. Things have to match our clinical signs and symptoms. There's the Schmall's node. The other thing, I put up osteophytes just because I find them fascinating. That is my body's healing gone a little bit awry. My body's doing its job, but not in the right place. So I told you that as I'm getting to 60, my disc is no longer filled with water, like this kind of putty. My disc loses a bit of height. That makes everything around that disc become a little bit loose. Can you kind of imagine that? So now I have a little bit of looseness, which means everything moves just a little bit more. And as everything moves just a little bit more, it stretches the ligament, and my body says, oh, I've got all this inflammation in a ligament attached to a bone. I'd better lay bone down to protect it. And that's where I get these. This is a lip in the anterior longitudinal ligament deep band. So it's actually a normal process, not usually a source of pain unless it occupies space and you have all those changes we talked about before. Stenosis, I threw up here just because it is identified asymptomatically. Instability we talked about already. So this is one of my favorite Far Side cartoons from the 90s. Oh, wait, hang on. Maybe it wasn't a herniated disc. All right, just to continue to hopefully drive this home until you're so bored you can't take it. All the randomized clinical trials that have looked at these type of things have shown that imaging doesn't change the outcomes of my management unless someone has that set of serious symptoms. That routine and regular imaging doesn't change how, and this is very egocentric, I know, PTs, OTs, osteopaths, how we would do our rehabilitation management. The other thing is if we're taking a lot of images, we have the potential to do some harm. Complete asequential Mark Bishop story, to step into a different story over here. So PTs in this country are fighting for the right to prescribe imaging. And I think there's a bit of a challenge with that because we already tend to over-image. And now if we have all these PTs sending you off to get an image, I don't know that would happen, but I think there's some harms associated with additional unneeded imaging. One is obviously we're all exposed to a little bit more of whatever it is. The other is the potential for serious interventions to be made based on the image. I just showed you that Schmall's node. You treat a Schmall's node by fusing things, pack it with bone. I mean, it's a big surgery. But if that was asymptomatic, then I've gone ahead and done this big surgery for something that isn't in fact the likely cause. So just things to think about. And then I thought Roger might be here and see if he recognizes this data. So this is from a group of people who look remarkably like first-year PT students, just saying. And what we did is line all them up and we put a very hot thing on their arm. 49 degrees Celsius is double it and add 30. So what are we, 110, 113? That's pretty hot. A lot of people will say that's painful. So what this is a graph of how those 100, how many people? 120 people rated that pain. We had some people rated as the worst thing they'd ever experienced. And we had one or two people say, oh, I don't really feel it. All intents and purposes, they had to do all their sensory testing. Everything was typical. There were no neuropathies. But kind of highlighting this thing that not everyone's pain experience is the same. We just talked about all these different pathologies. Even if two of us have exactly the same pathology, and it could be causing what we're experiencing is going to be, could be quite different based on the variability in how our nervous systems work. And I'm sure Dr. Fillingim talked about how we think about things and our beliefs and those type of things. Right? So, very, very common condition. All of us will have it at some point, just about. We kind of expect our bony elements and muscles and everything to change as we age. So chances are that we have pathology of remarkably high. Very, very hard, though, to link any of those specific identified anatomical changes to the pain experience. Talked about a couple of those things which are important. And then about 10% of people have those things. All right. So what now? Who's still awake? Who made it this far? Hey? A couple of people. All right. Thank you. Thank you for assisting. So what do we do? I remember giving this talk a couple of years ago to med students at UF and saying, well, why would we even bother then? So because there's so much we can do. So much we can do. A very simple thing to think about is if you rule out those serious, if there's a limited number of serious dangerous things to rule out the serious dangerous things. And then we have a really good chance to say this is a mainly joint thing. This is a mainly muscle thing. I'm a physio. We do joints and muscles like nobody else's business. Maybe it's a nerve thing. Right, you go and talk to some people who know about nerves. And movement is the key to all those things. Right, so for those people who are still awake, movement is really important in the back because my discs, right for the snorty sound, my discs don't have a great blood supply. They don't have a great nerve supply either, which we can talk about, but they don't have a great blood supply. Your vertebral bodies have a tremendous blood supply. I don't know if you remember your high school diffusion and osmosis and things like that, but the nutrition of the disc comes from the vertebral body, diffuses across the barrier there, and that's where it gets its nutrition. Now, the other thing you may have heard is generally we're a little bit taller when we wake up than when we go to bed. Because overnight, whatever hydrophilic function is left in our disc sucks in a bit of water, and our disc has a little bit more pressure in it in the morning than it does after we've been standing and sitting on it all day. So what that does is pump fluid in and out of the disc. Right, you lie down, you unload the disc, it expands a little bit, that sucks water out of the vertebral body. And then you stand up, and compression slowly forces fluid into our vertebral body. So movement is key, absolute key to disc health. A boring Mark Bishop story in 1984. The primary intervention for back pain that we had in Australia at that time was say, lie down, 7 days, don't move, I'm putting you on traction. Don't move. Turns out that was probably the absolute worst thing we could have done for somebody with back pain. So now if you're not moving, you don't get nutrition. And if you don't get nutrition, the tissue quality decreases. And if the tissue quality decreases, et cetera, et cetera. So movement is really key for disc health. The zygapophyseal arches, those joints at the back of the spine, need movement. And that's like flexion, extension, and flexion to keep those joint surfaces lubricated. Without that lubrication, the joint stiffens up, you get changes in other connective tissues, and it becomes problematic to move the joint. Muscle health and circulation, all predicated on movement. The other thing is the spine, while it is great, moving front back and absorbing loading, right, compression, it literally is just a stack of 33 bones on top of each other. Right? I mean, you just stacked up vertebrae like this. So you have to do things that engage the muscles that help stabilize. I'm not talking about core training or anything. You could do core training, but what people really are asking you to do is think about the deep muscles that stabilize your back. Right, I have a picture up here of someone. This exercise is an adapted bridge from yoga, but it's used quite commonly in rehab to try and get those deep muscles of your back working. The other thing, pardon me, is your backside. Very important muscle for controlling the pelvis and the back. Very important. The stronger, it's like range of motion in your hip and strength in your glutes allows you to control your trunk and pelvis with big muscles. Glutes is a big, strong muscle, as opposed to much smaller muscles that are designed to stabilize. So kind of keeping those muscular elements in their optimal health is also great for the longevity of your current condition and resolving any conditions that you have. The other thing is aerobic stuff, just for general health. There's anyone remember Fit or Fat? Late 80s, Cobert Bailey. He was an American exercise physiologist who was very popular in Australia. I guess, go figure. And he used to say, you need to do some exercise. So what exercise should I do? What exercise will you do? And so his point was the best kind of exercise is the one that you'll do. Right? So if I can tell you my favorite exercise, you might really dislike. Best type of exercise is the one that you'll do. The caveat to that is more than once. Right? So I say try everything. Find one you like. Rotate through. I'm sure people are doing things like, they're doing walking 1 month, maybe dancing, stuff like this. But each of those is going to be key to managing what's happening. If people have questions, I will try and answer them, but it takes a little while to go through and say, I think this is a predominantly muscular problem. Probably if you go and see chiropractic, PT, osteopath, it's going to take you half an hour, 20 minutes to get through and say, I think this is mostly muscle. I think this is mostly joint. But regardless of what they think the cause is, the intervention, guess what they're going to ask you to do? Move. Move the joints, do some strengthening of these muscles, and then they may do very specific, if it's a joint, has anyone had chiropractic or PT, you can kind of move the joints passively, stretch the limbs passively, but then you have to do something as well. All right. So I'm going to finish it up right here, leaving most people unsatisfied and take a couple of questions. Yes, sir.
Thank you very much. It was both entertaining and also educational.
How good.
I have actually two things. First of all, you mentioned it was the last thing on a list of things that you said caused weakness and numbness in the foot. What was that? And then the second thing is, does the science of does the science of spinal cord stimulators actually work?
Yeah, so to speak to the first thing there, anything that causes compression on a spinal nerve, that could be bone, like an osteophyte, or an arthropathy where the joint swells. It could be disc protrusion. It could be narrowing of the canal. But anything that compresses the nerve will give you that sort of numbness, weakness that could do, yes. Right, so it could be stenosis, it could stenosis from degeneration or instability, it could be herniation in the disc, it could be any of these things that push on that. And once it pushes for long enough, you start to get myelopathy as opposed to radiculopathy. Where radiculopathy is like sensory things and pain, and the myelopathy is, okay, this is compressed enough now that we're shutting off the stimulus to the muscle. There's some really good work in stenosis looking at treadmill walking as an intervention, walking as an intervention. For most people, for stenosis, and I'm sure you'll correct me if you have stenosis and I'm lying here, is flexion tends to make it feel better. And so if it makes sense, if I raise a treadmill up and I'm walking on the treadmill, that automatically flexes me, and most people can tolerate walking that way, walking in the pool, unloaded, there's a couple of harnesses, but getting that repetitive walking is really important for resolving the leg pain, and then working on your glutes and stuff.
The second question was, does the science of spinal cord stimulators actually work?
So there's some, once again, it's about in 50% of the people who end up getting a spinal cord stimulator, 50% of those people feel some relief. And so usually spinal cord stimulators aren't the first intervention, because by the time you're getting a spinal cord stimulator, you know, you've tried a couple of other things. The number of people who would probably respond to the stimulator as a first line intervention is going to be really small. So I did have done a review on the efficacy, and most of the time it's a trial, and they say, we're going to put this in. If we can reduce what you're feeling 50%, we'll call that a success. So that's, I think, at least what I've read. I'm not an anesthesiologist or a neurosurgeon, but that seems to be what the papers are saying.
Thank you very much. I'm here, sir. I came because I wanted to better understand the process I went through and why the surgery I had 10 days ago, 5 hours on the operating table, has resulted in no pain. For the last 2 years, I have been suffering. and taking Advil and Tylenol and Advil and Tylenol and gabapentin and I don't know what else. So now I understand much more in much more detail, but Dr. Maroney and his team were fantastic. And I want to give 3 cheers out for him, and don't be shy. Also about going without general anesthesia is not that bad. Much better than having your brain turned inside out by the general anesthesia at our age. Yes, it's me. So
I'm sure, I imagine a lot of people are wondering what causes the pain when somebody tells you, oh, I just bent over to pick that up and I couldn't straighten my back and I was in bed for 3 days. I had the same syndrome. It came on very gradually over a period of about 6-8 hours. But could you comment on acute back strain as described?
Yep. So there's probably 2 or 3 scenarios. I'll give you the most common one. If it's pain related to the intervertebral disc, only the outer maybe 1/6 or 1/3 of the disc is innervated. So it means only that portion is going to respond to nociceptive stimuli or injury. The other side of that statement is that 2/3 of the disc can be traumatized or torn or worn out, and I know nothing. And then I do something, and it wasn't that this was the thing that did it. I guess literally the straw that broke the camel's back, but the camel's back had been breaking for a long time before I did this. Does that kind of follow? So bending down to pick something up off the floor is not inherently by itself problematic. It's at the end of a cumulative load, and it could have been something very simple that did it. So that's one. The other sort of changes with the acute strains is, remember I was talking about the zygapophyseal joint. These joints, they're diarthrodial, they react like your ankle. If you twist your ankle, it gets swollen, hurts to move, you have to rest it for a few days, it's aching in your foot. And so the metaphor or the allegory I like to help people with is, say, imagine you've literally got 16 ankles up and down your back, and you do something suddenly and you sprain an ankle in your back, sprain a joint in your back, it's going to react the same way. It's going to hurt for 72 to 96 hours like the dickens. It's going to refer pain into your backside and to your leg probably, and then it will resolve over a couple of days. Well, so the question was, so if I get it incorrect, you let me know. So the question was, but why does your back go into spasm? Why does it lock up? Part of that is protective. I'm really sorry about that. I need a big one. Have you ever seen the big P? You put a foam thing over your microphone, so every time you go, it doesn't. So there's a protective phase where it says, okay, we're going to contract so you don't move because you just tore this ligament. You probably better not move it. That's the most commonly accepted theory. There's also, if it's related to the discogenic stuff, that it's neural, but in general it's to protect the place so you don't move it. And that's pain doing its job. So, I just sprained the ankle in my back. I should probably not be doing much for maybe 24 hours to let that swelling come down. Yeah.
There seems to be a wide variation in the burden of stenosis and back pain between populations. Is there a genetic component to low back pain? And is it behavioral, cultural, genetic, or what?
Mm-hmm. Oh, isn't that a deliciously complex question? So for stenosis specifically, I can't comment. There's definitely genetic familial degeneration in articular cartilage, which includes the intervertebral disc. So can I point to a specific gene? No. We do know when actually I was on a couple of projects with Roger Fillingim where we were looking at some of the genetics of pain to see could we predict which medication it would respond to. And when we started, I think there was 10 candidate genes. NIH on its website has more than 720 different genes and gene interactions that potentially affect how I process, how I transduct nociception, process it, and stuff like that. You like that hedging answer? I don't know. That's the answer to your question. I don't know if there's specific genes for stenosis. The other part, if I'm just going to finish up the part of the question, because the other question was very rich. It says, why can I have these two structurally similar sets of dysfunction and two profoundly different responses? This is going to get a little esoteric here, but a couple of years ago, we were part of a group that was trying to redefine pain. Now, every 20 years, we update the definition. And one of the definitions which didn't make it, but was my favorite at the time, was pain is a learned response to any threats to my physical or existential existence. And I think most people are pretty confident that pain behavior, how I react, me, not you, I learned how to respond based on family, friends, other sort of social influences. So my response to stimulus is partly socially constructed, culturally bound. So yes, that can explain. And my rating of pain is a behavior. If you want to get into it, we can. I was raised by psychologists. But pain intensity is a behavior. I'm telling you something. I had to think of it. I had to process it. I had to come up and say it. And great examples, I think, exist. I grew up in the South Pacific where we would play football against the Maori kids. When they turn 14, they get tattooed with a piece of bone. Knee to belly button. And if you make a noise, you're kicked out. All this, those guys were pretty tough, is what we would say. But I don't think it was toughness. I think it's the learned response to that stimulus is to be proud of becoming a man. So the learned response to that stimulus wasn't about pain and suffering. It was about the glory of men. And so that context is very different. You lay me down and tattoo me with a piece of bone, knee to my belly button, I would probably be crying a little bit, I think. Does that kind of answer your question somewhat? Yes, sir.
We have Jeannie here, and then we'll go to the Zoom questions.
Hi. I have all kinds of back issues, and people ask me what's wrong with my back, and I say it's easier to say what's not wrong with my back. But one of the things I have is 3 herniated discs.
Mm-hmm.
And the way you explain this, I want to make sure I'm clear on this. The herniation when you're young, it seems like that material goes back into your body. And then when you're older, it's drier and crumbles. That's when I got lost of why it's hurts more when you're older. If it's are those pieces poking on stuff or?
Yep. So the question, everyone hear the question pretty well? So as I age, the stuff that's going to end up in the canal is its chances of getting reabsorbed is very low. So now it's physically, I've got disc material just sitting in the canal, taking up space. If the nerve is irritated, the pressure is going to be painful right there. In someone who's younger, the toothpaste metaphor, that gets reabsorbed by my body. So initially it causes a lot of intense pain through the inflammatory reactions, but probably not much compression, or not as much. And then my body reabsorbs it. But if my disc has crumbled out and is taking up space, kind of like the cartilage parts of my disc, that doesn't get reabsorbed. So the question was about the PLA2 enzyme. It's gone. As I age, that in the level of that enzyme changes, and I think it's parallel to the glycoaminoglycan structure. So as I lose that gag from the disc, I lose the ability to have water, lose the ability to I lose the amount of that enzyme.
But if we keep exercising, we won't lose it.
Yeah.
Okay, let's go on to the Zoom questions, Mark.
Yes, ma'am.
Maybe you can go ahead and read out.
All right. In the 80s, someone from Duke acquired for episodes of iritis, inflammation of my eye. Ordered a lab test that tested HLA-B27, diagnosed me with ankylosing spondylitis. This is one of those rheumatological conditions I was talking about. It's eliminated my back pain, allowed me to do physical activities I haven't done since my 20s. At 73, I'm working on my fourth black belt in Krav Maga. Who is this? Paul, way to go. Nice work. Does strength training twice weekly.
Congratulations. Yeah. Next question.
Well, I'm just going to comment on that because
Okay.
the ankylosing spondylitis was one of those conditions I was talking about that we can be is one of the 10%. It's an inflammatory arthritis of this. Next question is, please move on to treatment options, particularly for compression fractures. Depending if the compression fracture is stable and the compression fracture is not compromising the nerve. Most of the time, nothing will happen. So avoid doing a lot of flexion. That'll compress the fracture even more. So you avoid maybe stretching your hamstrings, doing sit-ups while you're waiting for the bone to heal. If the fracture is unstable or is pressing on neurovascular tissue, they may need to fuse it so it doesn't collapse. But exercise is one of the best interventions for increasing your bone health. Do I have to preach about bone health here? All right, bone health is important. Keep moving, strength training, weight bearing. Typical loss related to fluid in the disc. A lot of it can be, as if my nucleus stops absorbing water, I lose several millimeters across 33 levels. A millimeter is, what are we going to say, quarter of an inch, eighth of an inch? I have 33 times 8 inches. That's a couple of inches. I lose that much at every disc. So there's that. There's also a change in I'm going to say thoracic posture, as sometimes people will tend to flex a little bit more. I advise to you to think about sitting up straight. You burn extra calories sitting up straight too, by the way. Extra 15 calories an hour that you can put in your exercise log because you sat up straight. It's using muscular activity. I slouch because I can use the ligaments and I don't have to burn any calories. I just hang on the ligaments in my back. And so you lose height sometimes if the position of the vertebral bodies changes, but definitely also through the water. Someone saying, can exercise resolve myelopathy? There's a really interesting set of papers called Disappearing Disc Disease, late 20th century, early 21st century, where they took people with big herniations identified on imaging who had symptomatic myelopathy and radiculopathy. And over the course of 3 years, One group got had a laminectomy and discectomy, and one group was treated conservatively. And after 3 years, discs look the same, symptoms look the same. Now, this wasn't progressive myelopathy. Let me be clear. If something happens, you have weakness and then you get weaker, that's bad. Go do something about it. You have a little bit of weakness in your big toe and you can't extend it and it's staying the same all the time, you might be able to do something about it if you are patient. So to do this sort of thing, it's me saying, this will work, but you need to do this every day for 3 years. I don't know about you, that's not how I respond. It's 3 years. I was hoping next week, maybe. Can it be better next week? No. 3 years. So we can conservatively manage these things. It just takes a long time. And I can say from my own perspective, I've become, it's weird how impatient I am the older I get. I thought I was supposed to get some Zen-like patience and be able to tolerate everything. I'm just more and more impatient. So I don't know. If you ask me, say, we can conservatively manage your hippo way by doing this incredibly painful stretch every day for 2 years, or what? Can we just operate, maybe change a little bit? Oh, so sitting, no, I do not want to imply that any one activity is bad or not. Sitting in your lazy boy for more than maybe 20 or 30 minutes is just generally bad. If sitting's the new smoking, and we just said that we need to move, then just sitting in a certain posture for half an hour is not bad. I'm never going to tell anyone, say, avoid this particular activity. Just avoid doing this particular activity for more than half an hour at a time.
Thank you so much, Mark. This has been wonderful talk. Enjoyed it and informational. Thank you. Next week, our speaker will be talking on sleep and pain and how aging change affects the sleep and pain connection. Should be very interesting.